so now you're going to do your ankle evaluation for the practical exam. You're going to do your hips evaluation, and you're just going to go through each step, one right after the other. We won't have a conversation back and forth discussing signs and symptoms, but you'll just explain what you're going to ask. So the first thing you're going to do is take a history. You're going to ask your 6 history questions. You remember what they are? Mechanism of injury, when and where it happened, whether it's chronic or acute. And you can explain a little bit with each one of these, what you're looking for. Unusual sounds, unusual sensations, chief complaint, and previous injuries. I think we nailed them all. But you can go back to your list. After we take our history, we're going to do our visual inspection. You're going to say that you're going to do your visual inspection bilaterally. You're going to look again for 6 things. You're going to look at his gait and posture coming to you to see if you can identify the severity of the injury or where the injury is. You're going to look for any swelling bilaterally, any deformity, discoloration, bleeding, or scars and abrasions. After you do your visual inspection bilaterally, you're going to palpate bilaterally. You're going to first tell me what you generally palpate for. Those are, again, 6 items, things that you can feel, so palpation. You're going to feel for the area of most tenderness, pain and point tenderness. You're going to feel for swelling, any deformity, which would be bumps or bruises, any dips or divots, maybe any fracture signs. You're going to feel for crepitus, which could indicate like a tendonitis in the Achilles tendon, or it could be 2 bone ends rubbing together if it was a fracture. You're going to palpate for temperature changes. If it's warm, it could be inflammation or it could be infection. If it's cold, it could be a decreased blood flow due to a blocked or limited artery. What else? Did we say anything? Pain and point tenderness, swelling, deformity, changes in temperature, crepitus, and you can palpate the pedal pulse, although we have this during the special test section too. Okay, so now we're going to go to our specific palpations. We're going to go to our bony palpations. You're going to need to palpate these structures and know where they are. You're going to palpate down the fibula, all the way down, feeling down the lateral malleolus, and down the tibia, all the way down to the medial malleolus. You're going to palpate the calcaneus, back. The talus sits all the way in this ankle mortise and through the front here. And on the inside of the foot, you're going to palpate the navicular, which is right at the mid-arch. And then for a soft tissue palpation, you're going to palpate the ligaments on the lateral side, which are most commonly injured in an inversion ankle sprain. You're going to palpate the anterior talofibular ligament. You can invert the ankle a little bit and have the calcaneofibular ligament pop out. You can palpate the anterior talofibular ligament, which is right in front here. It's right under the lateral malleolus, so it's not down here, but right underneath. You should feel that little thickening in the capsule. The anterior talofibular is the one that's most frequently injured. It's the first one injured in an inversion ankle sprain. It's going straight down is the calcaneofibular. It's usually easier to see and feel. And then the posterior talofibular ligament is a thick one on the back side right here, on the posterior aspect. Then you're going to palpate the deltoid ligaments on, you can't see it from here, but on the inside, the 4 ligaments that make up the deltoid, that little triangle shaped ligament. And then on the back side, you're going to palpate down the calf, the Achilles tendon to where it attaches on the calcaneus. So that's your bilateral palpation. And then you're going to go into your special tests. So if they were on the field and you want to make sure that they weren't, that you could safely remove them from the field, you do a quick fracture check if you think that was necessary. So you can do an indirect compression test. And so you're going to go above the site that you think is fractured and see if it causes pain down below. You're going to do the heel tap test. Again, this time you're going below the general fracture site, which is usually the fibula, to see if that creates any irritation specifically on a fracture site. We can check out can do the Thompson test, and I can have you just flip over on your tummy really quick. With the Thompson test, if you bring this leg up, if I squeeze his calf and his Achilles tendon is intact, you can see that the foot plantar flexes, okay? And you can see the Achilles tendon contracting up. So that means the Achilles tendon is not ruptured, so that's a Thompson test. Okay, go ahead and flip back over. Then we can check for ligament laxity. First thing we're going to do is do the drawer test. This checks for laxity in the anterior talofibular ligament. You have to make sure that your patient is relaxed, his knee is bent. You're going to keep moving back and forth just to make sure that he doesn't tighten up. You're going to grab his calcaneus with your fingers. His foot is going to be resting on your forearm. You're going to use your other hand to stabilize. And again, you just kind of make sure that they're relaxed. I move my arm up and down. When I feel them totally relaxed, I hold on and then I glide that talus toward me to see if what you're looking for is the talus moving greater than 4 millimeters in an anterior direction or towards you. Okay? The next one, you have Hector scoot back, and he's going to do the Taylor tilt test, or you're going to do the Taylor tilt test. Again, all tests are done bilaterally. For this one, normally you would take this shoe off, and you're going to move the foot into inversion. Again, you don't want to rotate it. You want to do just pure inversion. And this one actually is rotating a lot more. Is that the one you've injured before?
Yeah, I ended up.
Okay, you're looking for a greater than 10 millimeter difference, and then into pure eversion. So again, pure inversion, and then pure eversion, not rotation, anything like that. So again, make sure you're doing pure inversion and eversion. The next thing you're going to do is to check the range of motion. So you're going to have him go into dorsiflexion. This is active range of motion where the athlete's moving. Dorsiflexion, then move into plantar flexion. I'm looking bilaterally, out into eversion. Okay, again, not rotating here, but rotating at the ankles. And then to inversion. Good. If I saw some limitations, then I would passively move them through the ranges of motion to see if it was due to a bony block, or to weakness, or to pain. And then you do a resistive to check their strength and neurological function. So push up and push down, push out into eversion, and then into inversion. And then again, we do want to make sure that we're checking that pedal pulse. Pedal pulse is right medial to the big tendon on the toe, okay, which is the dorsalis pedis pulse. And that's it.